Hello, my name is Dr. Peter Panagos. I'm a professor of emergency medicine and neurology at Washington University School of Medicine in St. Louis, Missouri. It is my pleasure today to introduce Dr. Suja Rajan, who works at University of Texas School of Public Health in Houston. And today at ISC 2020 at the main event, we had the pleasure of hearing her presentation entitled The Economic Evaluation of the Benefits of Stroke Treatment Delivered Using a Mobile Stroke Unit Study. This was a fascinating discussion looking at the economics behind mobile stroke units. So my question to you is, many people consider mobile stroke units quite expensive to purchase and operate. What did your study find?
So my study found that, the upfront investment is expensive, but because the unit gets care to the patients as soon as possible, it saves lives for sure, and also makes sure that the quality of life after stroke care is much better because of the mobile stroke unit. And so that saves costs for the patients and the health system as well. So the downstream cost savings, stroke-related cost savings, offset the upstream expense. And of course, it depends on what type of area they're operating in and population density and everything, but that's what our study finds.
So tell us a little bit about the methodology behind this study. How was it designed?
So it was designed in tandem with our original study that looked at the clinical outcomes. It's an observational prospective study. Okay. With alternate week design. That is, we alternated the mobile stroke unit service with the standard management, and observed the outcomes for these patients at discharge in 90 days and throughout the year to see how they did in terms of cost and in terms of outcomes.
Okay, and what did you find?
So we did find that, especially when we focused on stroke-related outcomes and stroke-related costs, the mobile stroke unit patients did better than the standard management. So in terms of the costs, stroke-related costs were saved for the mobile stroke unit patients, which kind of offset the upfront investment, and their outcomes were better, the quality of life was better. So that kind of justified the initial upfront investment.
Okay. For the patient population that was enrolled in your analysis, were they fairly generalizable to the population that we would see in most cities and territories across North America?
Yeah, definitely. So we did have our largest patient base came from Houston, and then we also had a site in New York City, Los Angeles. So yes, these cities are very diverse in terms of the patient population and are very generalizable. And also we did have, as compared to many other clinical trials, we did not have trouble recruiting minority groups, which is a big positive because we have more data in terms of minority outcomes in health. So yeah, in terms of that representation, it's a very well-designed and well-conducted study.
Oh, great. Are there any particular patient populations within your analysis that fared better or worse than others?
Yes, patients who had lesser disability at baseline when they had the stroke did better.
And how was that measured?
So we did measure disability at baseline based on whether patients needed caregivers at baseline, whether they were staying at home or in a facility, and also did the usual clinical outcome measures like Rankin scales at baseline to know their disability levels.
Very good. So individuals who were at least impaired or are close to being normal at entry of the analysis tended to do better.
Tended to do better,
Okay.
yeah.
Any thoughts on why that was true?
Well, that is to some extent expected, right? So in terms of how patients would do if they have stroke and if they were better off and healthier to begin with, they have higher chances of going back to that after rehabilitation than someone who already has a disability.
Okay. So we're at ISC 2022, where we talk about basic science and clinical efficacy and outcomes. So this was an economic analysis. So tell me some of the numbers and dollars that kind of came out of your analysis.
So in terms of the dollars, one of the things that we looked at was in terms of investment and operations for these mobile stroke unit. We found that per year costs for these units were almost close to $500,000 per year in terms of personnel, maintenance and operations, and also the amortized unit cost and things like that. And then over time, some of the cost savings for the patients, if we particularly looked at stroke-related healthcare utilization costs.
Okay.
So for example, from the perspective of, say, CMS, if Medicare pays for these healthcare utilization costs, their stroke-related costs were about $1,600 lower after adjustments for the mobile stroke unit patients as compared to standard management.
Understood.
And these costs mostly came from utilizations like long-term care and nursing home care, in rehospitalizations in inpatient settings and stuff like that.
Okay. Did the number of patients treated per MSU make a difference in your outcome at all?
Yes, it did. And so, yeah, in terms of, because there's a huge capital investment,
Right.
For these type of interventions to break even and justify the initial upfront investment, sufficient number of patients have to be treated per year. So that is something we would like to look at even in future in terms of, what type of population densities and what type of cities these are more effective in.
Mm-hmm.
But the more patients we treat per year, the more cost effective the intervention is.
And I understand there's lots of variables, what type of MSU you purchase, what part of the country you are working in, so costs are going to vary. But in general, is there a number of patients treated that needed to be achieved to kind of break even?
So if we are purely looking at costs and not patient-related outcomes, if you don't take the quality of life into consideration, we would have to treat somewhere close to 250 patients per year to break even. But this is if you're only looking at costs, and that would be unfair because then we are not considering the patient-related outcomes.
Exactly.
So once we consider the patient-related outcomes and the type of benefit it brings to the patients, potentially returning back to work, reducing costs for insurance companies and payers, in terms of the quality-adjusted life years and other factors, we should be probably treating around about 100 patients per year for the unit to be justified in terms of outcomes.
That's a fascinating number. That would probably be the number that most MSUs are treating across the country right now, at least. So, very interesting.
Well, yeah, I mean, it depends on the city too. Like, more densely populated cities will probably get there.
Understood.
But, yeah.
Okay. Any other findings that our audience may find interesting?
Well, I think one of the other was also that we did find that some of the demographic factors had an impact on costs and outcomes. And so because we had a very well-represented study, we were able to look into that and adjust for that.
Okay. Which factors did you initially find before adjustment that were impactful?
Definitely race ethnicity was impactful. So yeah, that and most of the others were clinical factors. So yeah.
What is the intended audience for this study? Who do you think is going to find it interesting and pay attention to this?
I would think large health systems would definitely find it interesting. EMS services, CMS should be very interested because they pay for all kinds of care. Medicare pays for short-term care, long-term care, rehabilitation. So this is definitely something that is of interest to them in terms of what they might save and what they should be paying for.
Great. And you alluded to some of the ideas in your platform presentation today. What are the next steps?
Well, next step, at least from the economic perspective for me, is to look at regions logistically to try and figure out what type of regions might benefit most from these. Clearly, big cities are benefiting because they're more densely populated and have more incidence of stroke. But in terms of treating patients that are more remotely located, it would be interesting to see what might be best to get them treatment as quickly as possible. Because I mean, for each patient, every life saved for them is worth millions, right? But for the system, what does that mean, and how do we make sure we are equitable in getting this care to patients that are more remotely located and in rural areas and things like that?
Okay. Well, Dr. Rajan, thank you very much for your time. We appreciate it, and congratulations on presenting your science.
Thank you.
Thank you.